Good afternoon, everybody. As people are starting to log in, we're going to start our pediatric grand rounds this week. Welcome. I think I've mentioned this many times before, but we have an interprofessional planning committee that helps us decide on the topics and the different speakers that we should get to our pediatric grand rounds to make sure that we offer a broad set of ideas. And it's a great pleasure to have one of our outstanding nurse practitioners, Meredith Russell, who's part of our planning committee and who came up with this speaker and topic. Introduce our speaker for today, Meredith.
Thank you. I am so excited to introduce Dr. Misra, whose interest in her field and topic today rose from her interest in the impact of nutrition on endocrine systems and her early studies in girls with anorexia nervosa. Dr. Misra is the chief of the Division of Pediatric Endocrinology at Massachusetts General Hospital and also the Talbot Professor of Pediatrics at Harvard Medical School. She is the immediate and past president of the Pediatric Endocrine Society and currently serves as the Associate Director of the Translational and Clinical Research Center at Mass General and the Medical Research Officer for Massachusetts General Hospital through the Harvard Clinical and Translational Science Center. She's also the Director of the Pediatric Endocrine Neuroendocrine Sports Endocrine Laboratory at Massachusetts General Hospital. Dr. Misra specializes clinically in pituitary and bone disorders. She is internationally known for her work on neuroendocrine, metabolic, and bone complications of disorders that span the weight spectrum from severe undernutrition all the way to obesity, as well as autism spectrum disorders, and her work has led to major strides in the clinical management of related conditions. I'm pleased to present Dr. Misra, and her discussion today will be oligomenorrhea in young athletes, consequences and management dilemmas. Thank you so much for joining us today. Dr. Misra.
Thank you so much, Dr. Russell, for that introduction and for the invitation as well. So I will just jump right in. So these are my disclosures, none of which are really relevant to the content of the talk today, except that I will be discussing the off-label use of IGF-1, which is manufactured by Ipsen. So ever since Title IX went into effect in 1972, providing everybody with equal access to any program or activity that receives federal financial assistance, including sports participation among girls has increased more than tenfold. And at this time, about 28 million women participate in running sports in the United States every year. And while we know that sports participation has many benefits, we also know that excessive physical activity can be deleterious and can lead to what's referred to as the female athlete triad. So the triad is the triad of low energy availability, menstrual dysfunction, and low bone density. But the triad is in fact a spectrum or three spectrums, with energy availability ranging from optimal to reduced to low, menstrual function ranging from ovulatory eumenorrhea to subclinical menstrual disorders to frank oligomenorrhea, and bone health ranging from optimal to low bone density to frank osteoporosis. So what I'd like to do today is to review with you the components of the triad, and we'll start with low energy availability. So energy availability is defined as the difference between energy intake and exercise energy expenditure standardized for fat-free mass. And this is believed to be optimal when it's more than 45 kilocalories per kilo fat-free mass per day, and low when it's less than 30 kilocalories per kilo fat-free mass per day. And these numbers come from a series of very elegant experiments by Anne Lauck's group, in which women who were normally menstruating and non-exercisers were subjected to different degrees of energy restriction in a clinical research center setting. And the investigators showed that when energy availability dropped to less than 30 kilocalories per kilo fat-free mass per day, there was a change in the pattern of LH pulsatility, which became increasingly more profound with further energy restriction. So energy availability is likely to be low when there's a very high volume of activity with increased energy expenditure, but with insufficient dietary intake leading to a state of relative energy deficit. And there are certain kinds of sports activities and sports people that are more likely to develop this condition. And these include athletes who are engaged in endurance sports, such as runners and cyclists and swimmers, rowers, those engaged in leanness sports, such as gymnasts, divers, and ice skaters, and those engaged in sports that are associated with a lower body mass index and increased dietary restraint, which would include all of the sports activities I just mentioned. And moving on to menstrual function. So this, of course, is the hypothalamic pituitary gonadal axis. So the hypothalamus secretes gonadotropin-releasing hormone in a pulsatile fashion, which then stimulates the pulsatile secretion of luteinizing hormone and follicle-stimulating hormone by the pituitary gland. And these hormones will in turn lead to ovarian folliculogenesis and the secretion of estradiol and progesterone, and also to a lesser extent, testosterone and dehydroepiandrosterone. Now, DHEA is a product of the adrenal glands as well, but the ovaries also will produce DHEA. Now, in conditions of low energy availability, there are many endocrine changes that occur that impact gonadotropin-releasing hormone pulsatility in an adverse fashion. And these include higher concentrations of cortisol, ghrelin, PYY, and adiponectin, and lower levels of leptin, insulin, and IGF-I. And I'll be talking about some of these hormones at greater length in subsequent slides. But with this disruption of GnRH pulsatility, there is impaired gonadotropin pulsatile secretion and a decreased secretion of the gonadal steroids. And we think of these changes as adaptive to the state of undernutrition because reproduction, as you know, expends a significant amount of energy. And during conditions of energy deficit, energy really needs to be conserved for the most vital of body functions, and reproduction is not one such function. Now, menstrual dysfunction is reported even in normally cycling eumenorrheic exercisers, so exercisers who were having regular periods. And this was demonstrated very nicely in the study by Mary Jean D'Souza's group that showed that a very large proportion of eumenorrheic runners have luteal phase defects, which is a shortened luteal phase, and anovulatory cycles compared to sedentary controls. And at the extreme end of the spectrum of menstrual dysfunction is frank oligomenorrhea, or irregular to absent menses. And the prevalence of this depends upon the nature and the intensity of exercise and the nutritional status of the athlete. And it has been reported in up to 62% of adult athletes and in up to 24% of adolescent athletes. So it's very prevalent. Now, functional hypothalamic amenorrhea refers to amenorrhea that occurs in the absence of any organic pathology. That's why it's functional. And this is seen in conditions of excessive exercise with or without low body weight, low weight conditions such as anorexia nervosa, and also in conditions of excessive stress. And both excessive exercise and the low weight conditions are conditions of energy deficit, either because of increased activity or decreased energy intake or both. And in 2017, a group of us got together to write the Endocrine Society guidelines for the diagnosis and the management of functional hypothalamic amenorrhea. And I will be referring to these guidelines several times over the course of the talk today. Now, the diagnosis of functional hypothalamic amenorrhea is really one of exclusion, and this is best demonstrated with an example. So here is a 17-year-old young woman who presented to my clinic with a history of multiple stress reactions and fractures involving the distal femur and the tarsal bones. She had attained menarche at 13 years, so that's a normal age for the onset of menses. But since menarche, she's had only 5 spontaneous menses, so she certainly has oligomenorrhea. She also reports that she's a cross-country runner, and her growth charts show that she's had a low body weight for height for many years. So these are obviously important red flags. Further, she reports a history of significant headaches off and on. Now, on physical exam, the weight is at the 54th percentile, so that seems very normal, except that she's very tall, and her height is at more than the 95th percentile, giving her a body mass index of 18.5, which is at the lower limit of what would be considered normal. And at the 12th percentile, we ideally want BMI to be above the 10th and preferably above the 15th percentile. And her percent ideal body weight is only 86% based upon median BMI, and we want this number to be more than 90%. So this suggests a low body weight for her height. She's bradycardic, the blood pressure is normal, and the exam is otherwise unremarkable other than for some mild hirsutism. She's fully pubertal. So what would you like to do at this point? Now, the workup of amenorrhea in athletes includes ruling out multiple conditions. So you want to rule out pregnancy, thyroid dysfunction, hypogonadotropic and hypergonadotropic hypergonadism, conditions of hyperandrogenism such as PCOS, non-classic CAH, adrenal tumors, differences in sex development, and medications that can cause amenorrhea. The history should be, both the history and the physical exam should be targeted at ruling out these conditions, but should also include, the history should include an evaluation of the volume and nature of activity and the eating patterns of the individual. And the physical exam should include an evaluation of the external genitalia, including the hymen, to determine whether it's imperforate, because that can lead to cryptomenorrhea and an absence of menses. So here are the labs that we would typically get to work up amenorrhea, and this patient was not pregnant. Her thyroid function was normal. She did not have high prolactin levels. The gonadotropins were not elevated, so this was not primary ovarian insufficiency. And there was a pattern of FSH predominance, which is very commonly seen in functional hypothalamic amenorrhea. The estradiol levels were very low. Testosterone was low normal. The adrenal androgens, dehydroepiandrosterone and its sulfate, were normal. And 17-hydroxyprogesterone was not done because she had such minimal hirsutism that it really did not merit a workup for non-classic CAH, which is what the 17-hydroxyprogesterone would be used to assess. So what would you like to do next? Would you want to get a morning 17-hydroxyprogesterone? And like I just said, we didn't want to do that in this patient because of the very minimal hirsutism. It was going to be very low yield. Now, what about a progestin challenge test? So what is this? So this is a test where we give an oral progestin for 5 to 10 days. And if the uterine endometrium has been exposed to a sufficient amount of estrogen, after the 5 to 10 days of progestin, a withdrawal bleed should occur in 3 to 4 days. And this is a good test for patients with secondary amenorrhea after ruling out other causes of amenorrhea as an assessment of the degree of estrogenization of the uterine endometrium. So this would be a reasonable test in this patient. And what about an assessment of the internal genitalia by a full bimanual or pelvic exam versus imaging studies? And then in teenagers, particularly those that are not sexually active, we typically would not do a bimanual examination, but we would potentially do an imaging study. And the pelvic ultrasound is preferred as the first step, just given the expense of the MRI. So the Endocrine Society guidelines indicate that in a patient with suspected functional hypothalamic amenorrhea, the recommendation is to exclude pregnancy, perform a full physical examination, including a gynecological exam to assess for organic etiologies of amenorrhea. And the gynecological exam in most young non-sexually active teens includes an external exam, but not a bimanual examination. And a pelvic ultrasound would be appropriate to assess internal genitalia, depending upon the situation. And a brain MRI may be required in selected situations because this is a state of hypogonadotropic hypergonadism, particularly if there is concern for intracranial pathology, given a history of headaches, nausea, vomiting, or such. So our patient had a negative progestin challenge. She did get an ultrasound, and that was normal. And we did get an MRI on her because of the history of very significant headaches, and that was normal as well. So at this time, we really ruled out other causes of amenorrhea, and the diagnosis is consistent with functional hypothalamic amenorrhea from excessive physical activity. And so what would you like to do as the next step? So that brings me to the third component of the triad, and that's low bone density. And assessing bone density by DEXA would be a very reasonable next consideration in such patients, because this is a major consequence of the low energy availability state and the menstrual dysfunction that occurs in these young women. So in the next few slides, I'll be talking about the impact of excessive physical activity on bone health and the factors that contribute to impaired bone health. Now, mechanical loading per se has beneficial and adaptive effects on bone. And so with mechanical loading, there is a stimulation of the osteocytes, which are the mechanosensors of bone. And this leads to a decrease in sclerostin. And sclerostin is a hormone that typically would inhibit osteoblastic activity and bone formation. So with a decrease in sclerostin, there would be an increase in bone formation and an increase in bone density, which is really important to withstand the impact of these loading activities on bone and to prevent fracture. However, these adaptive effects of mechanical loading are lost in conditions of low energy availability and hypogonadism. And this is a study that we did many years ago, and this was a study in normal weight athletes, mostly runners and non-athletes between 12 and 18 years old. And shown here are the bone density Z-scores for different sites for the oligo-amenorrheic athletes in red, the eumenoweak athletes in the lighter blue, and the non-athletes in the darker blue. So the Z-score compares one's bone density to the mean for age and sex, and a Z-score of 0 would be considered average. So this paper was first authored by Carla Cristo in our group. And the figure really shows that the oligo-amenorrheic athletes have lower bone density Z-scores at the lumbar spine than the eumenoweak athletes and the non-athletes. And at the femoral neck and the total hip, the eumenoweak athletes have the adaptive increase in bone density that I talked about compared to the non-athletes, but this adaptive increase is not seen in the oligo-amenorrheic athletes, whose bone density Z-scores are lower than the eumenoweak athletes and approximate that of the non-athletes. We're particularly concerned about the impact of athletic amenorrhea on adolescence, because adolescence is a time when marked increases occur in bone accrual towards the attainment of peak bone mass, which is a very important determinant of bone health and fracture risk in later life. And if there is any condition that leads to suboptimal bone accrual during puberty, that could lead to suboptimal peak bone mass and therefore impaired bone health and increased fracture risk in later life. And if this dashed line is the fracture threshold, we can see how a woman who attains a normal peak bone mass would get to the fracture threshold much later than somebody who attains a suboptimal peak bone mass. So we have looked at bone accrual in athletes and non-athletes and have shown that over a one-year period, the eumenoweak athletes in the lighter blue have a continued increase in bone density Z-scores that is not seen in the oligo-amenorrheic athletes shown in red. Now, there are issues with DEXA measures of areal bone density, and that while this is a good clinical way to assess bone density, it measures areal and not volumetric bone density. So what does that mean? So bone density is bone mass divided by bone volume, because density is mass over volume. But DEXA measures, or DEXA reports bone density as bone mineral content divided by cross-sectional bone area. So it's reporting the areal versus the volumetric bone density. And areal bone density underestimates bone density in short people, and it overestimates bone density in tall individuals. And so it's really important to adjust for height in very short and very tall individuals. Also, DEXA does not provide any information about the cortical versus the trabecular compartments of bone. And it also doesn't provide any information regarding bone geometry or bone structure. And these are important, at least from a research perspective, because these are all very important contributors to bone strength. So we've used high resolution PQCT shown here to assess bone outcomes. And this is an instrument that allows us to measure compartmental volumetric bone density, bone geometry, so cross-sectional area of bone, both for the cortical and the trabecular compartments, and cortical thickness, and bone microarchitecture, which includes cortical porosity, so how porous is the cortex. And we can see that this cortex to the right is much more porous than the cortex to the left. And it also allows assessment of trabecular connectivity, so the thickness, separation, and number of trabeculae. Also, we can use a technique called finite element analysis to determine strength estimates. And this is a form of analysis where we apply virtual compressive forces to virtual reconstruction of bone from HRPQCT images to determine the breaking strain of bone. And HRPQCT is performed at the distal radius, which is a site of non-weight-bearing bone, and the distal tibia, which is a site of weight-bearing bone. So I won't have the time to show you all the data for HRPQCT, but I'll just summarize those data with a finite element analysis of measures of bone strength. And this was a study in athletes and non-athletes between 14 and 25 years old, first authored by, and this particular paper was first authored by Kate Ackerman. And we showed that at the distal tibia, again, a site of weight-bearing bone, the eumenoweak athletes in the lighter blue show the adaptive increase in bone strength compared to the non-athletes, which is not seen in the oligo-amenorrheic athletes in red. And at the distal radius, a site of non-weight-bearing bone, the oligo-amenorrheic athletes have lower bone strength than the non-athletes, with the eumenoweak athletes being in between. And all of this translates to a higher prevalence of all fractures, and particularly stress fractures, in the oligomenorrheic athletes compared to the eumenorrheic athletes and the non-athletes. So what are the factors that contribute to this impaired bone health that we see in athletes with amenorrhea? So there are many factors that contribute. Nutritional status is one. So low body mass index and low lean body mass, and we'll talk about that in a minute. The state of hypogonadism is an important contributor. Also, there is a state of growth hormone resistance. There is relative hypercortisolemia, and there are alterations in many appetite regulating hormones and other hormones that I won't have the time to talk about today, all of which contribute to impairment in bone health. Now, with regards to calcium and vitamin D status, the intake of calcium and vitamin D is often quite sufficient in these young women because of increased use of supplements. And at least in our studies, we have not found that a deficiency of calcium or vitamin D contributes significantly to the impairment in bone health that is so characteristic of this condition. Now, as I go through the next few slides, going through these mechanisms, I'll show you data for for the amenorrheic athletes, but where we do not have data for amenorrheic athletes, I'll show you data from adolescents with anorexia nervosa, which is another condition of very low energy availability. So starting with nutritional status, as I alluded to before, both body mass index and lean body mass are important positive determinants of bone density and bone strength. And we've shown that as body mass index goes up, the increase in lean body mass that occurs is very predictive of increases in bone density, speaking to the important role of improving energy availability and optimizing weight status. With regards to gonadal function, estrogen has many important effects on bone. It inhibits osteoclast-induced bone resorption through its effects on osteoprogesterone and rank ligand secretion by osteoblasts. And it also increases bone formation by inhibiting the secretion of sclerostin and pre-adipocyte factor 1 that I'll come back to a little later. And our studies and others have shown that the duration of amenorrhea, so the duration of hypogonadism, is very predictive of the extent of bone loss in conditions of functional hypothalamic amenorrhea, speaking to the role of estrogen replacement in these conditions. Now, testosterone and dehydroepiandrosterone are also gonadal steroids that have effects on bone, and these effects are mediated through their aromatization to estradiol or estrone, although they also have direct anabolic and anti-resorptive effects. Now, moving on to the growth hormone IGF-I axis. So the pituitary gland secretes growth hormone that stimulates IGF-1 secretion in the liver and also locally in bone, and growth hormone both directly and through IGF-1 is bone anabolic. And we've shown in studies of girls with anorexia nervosa that these girls have significantly higher growth hormone concentrations than healthy controls when measured overnight by frequent sampling every 30 minutes. And we think of this as an adaptive change also because growth hormone is a gluconeogenic hormone, and an increase in the gluconeogenic hormone would be an appropriate adaptation to maintain a state of euglycemia in a condition that is prone to hypoglycemia. But despite the higher mean growth hormone concentrations in anorexia nervosa, levels of IGF-1 are significantly lower than in controls, and this suggests that there is a state of growth hormone resistance at the level of the liver that is nutritionally acquired. And similarly, we've shown lower IGF-1 levels in athletes with amenorrhea compared with non-athletes, with the eumenorrheic athletes being in between. Now, this figure shows the association of growth hormone concentrations with osteocalcin, which is a bone formation marker. And in the healthy controls in blue, we see the expected positive association between growth hormone and osteocalcin. And this is expected because growth hormone is bone anabolic. But in the girls with anorexia nervosa in red, despite their higher growth hormone concentrations, we see that this association is completely lost, indicating that there's probably a state of growth hormone resistance also at the level of bone in conditions of energy deficit. So low IGF-1 levels are associated with low bone density, and low IGF-1 levels also have a deleterious effect on ovarian function, and this suggests a role for IGF-1 replacement in conditions of energy deficit. And here is the hypothalamic pituitary adrenal axis. So the hypothalamus secretes corticotropin-releasing hormone that stimulates ACTH production by the pituitary gland that then stimulates the adrenal glands to secrete cortisol. And cortisol, when it's made in excess, has multiple deleterious effects on bone. We've shown that amenorrheic athletes have significantly higher cortisol concentrations measured overnight by frequent sampling as compared to eumenorrheic athletes and non-athletes. And high cortisol levels are also known to suppress gonadotropin-releasing hormone secretion. And this figure shows the inverse association between cortisol and LH area under the curve. So the girls who have the highest cortisol concentrations have the lowest LH area under the curve, consistent with this feature of high cortisol concentrations. Also, high cortisol levels lead to lower bone density in conditions of low energy availability. And these levels of cortisol will improve, so they'll go down with weight regain, emphasizing the importance again of weight regain in functional hypothalamic amenorrhea. And finally, here are the appetite regulating hormones that I'm going to talk about today. So I'll discuss leptin, ghrelin, and PYY. There are many other appetite regulating hormones as well that go awry in these conditions. So leptin is an anorexigenic hormone, as is PYY. Leptin is secreted by adipocytes, PYY by the distal gut in response to food intake. And ghrelin is an orexigenic hormone secreted by the fundus of the stomach. And all three hormones have an impact on bone. So PYY inhibits osteoblastic bone formation, while leptin and ghrelin are bone anabolic, particularly when it comes to appendicular bone for leptin. And we've shown in the study that was first authored by Carla Cristo that amenorrheic athletes have lower levels of leptin and higher concentrations of ghrelin and PYY than the eumenorrheic athletes and the non-athletes. And we think of the lower leptin and the higher ghrelin as, again, adaptive, because in a condition of undernutrition, you want to have lower levels of an anorexigenic hormone and higher concentrations of an orexigenic hormone to try and stimulate food intake, and that's what we're seeing. What we don't understand is why PYY, which is anorexigenic, is high in the amenorrheic athletes, because the appropriate adaptation would have been to suppress this anorexigenic hormone. And there has been some question raised whether this could be contributory to reduced food intake in these conditions of functional hypothalamic amenorrhea. Now, ghrelin, PYY, and leptin also have an impact on the hypothalamic pituitary gonadal axis, which is inhibited by high ghrelin and PYY and the low leptin levels that we see in these conditions. And shown here are inverse associations of ghrelin with LH and positive associations of leptin with LH in amenorrheic athletes. So the girls with the highest ghrelin and the lowest leptin have the lowest LH pulse mass. Further, these hormones impact bone, as I showed you earlier, and ghrelin, which is bone anabolic, we've shown is positively associated with bone density in controls, but not in conditions of low energy availability, suggesting a state of ghrelin resistance. And leptin, which is bone anabolic, is positively associated with bone density in these conditions, suggesting a role for leptin replacement, and I'll come back to that a little later. And PYY, which inhibits bone formation, we've shown is inversely associated with markers of bone formation and also with bone density, suggesting a role for a PYY antagonist. So to summarize what I've told you so far, low bone density is prevalent in oligomenorrheic athletes, and it's associated with a higher risk of fracture, particularly stress fractures. And there are certain kinds of sports activities that increase the risk for low bone density. The mechanisms of low bone density include reduced BMI and lean body mass and several endocrine changes. And now let's move on to the management of low bone density. So when do we assess bone density and when do we treat low bone density? So the Endocrine Society guidelines indicate that a baseline bone density measurement by DEXA should be obtained in any adolescent or woman with 6 or more months of amenorrhea, or even earlier if there is a history or suspicion of severe nutritional deficiency, if there is another energy deficit state, or if there is a history of skeletal fragility. And the sites that are used for assessment of bone density are the spine and the whole body less head for children and adolescents, and the spine and the hip for adults. Now, what about athletes? What is low bone density in an athlete? How is this defined? Now, the International Society of Clinical Densitometry generally defines low bone density as a Z-score of less than -2. But an important question is whether this cutoff should hold for athletes who are engaged in weight-bearing sports. So I've told you that mechanical loading should lead to an increase in bone density above average to withstand the impact of increased bone loading. I've shown you that eumenorrheic athletes have higher bone density than non-athletes. And Michelle Barak's group has done some very nice studies showing that particularly in runners, a bone density Z-score of less than -1 rather than -2 is predictive of stress fractures. And based upon these studies and this kind of information, the Female Athlete Triad Coalition has indicated that for runners, a bone density Z-score of less than -1 should be considered low. And our patient had very low bone density Z-scores at the spine and at the hip, particularly at the spine. The Z-score was -4.7, and at the hip it was -2.4. So this is very, very low. So what is the next step in her management? And this brings us back to these mechanisms that contribute to impaired bone health. So we need to think about fixing these mechanisms. So first of all, we need to fix the low energy availability state, and that requires a multidisciplinary treatment team that focuses on lifestyle interventions to address low energy availability by increasing intake or reducing expenditure or both. It is important to optimize micronutrient intake as well, and this includes calcium and vitamin D. So we want to maintain 25-hydroxy-D levels in the normal range and to ensure that the patients are receiving at least the recommended dietary allowance for vitamin D and for calcium. And this is the treatment team that we would typically include in the management of these patients. A sports dietitian is essential. The physician kind of coordinates care. We definitely want the parent and the athletic trainer or coach to buy in. And a mental health professional is very important, particularly if there is a history of a disordered, an eating disorder, or if there's a pattern of disordered eating. Now, in low-weight individuals, weight gain is essential for the spontaneous resumption of menses and to improve bone density. And the goal should be to aim for a body weight above that at which menses were lost. And this is based upon a study by Neville Goldin's group showing that at the time of menses recovery, girls with anorexia nervosa on an average had a body weight that was 2 kilograms greater than that at which menses were lost. And the average body weight at the time of menses recovery in the study was about 91% of what would be considered ideal for height and for age. But as you can see, there was significant variability in this number, suggesting that the set point for menstrual recovery likely varies greatly from one individual to another. Now, this study also showed that it can take 6 to 12 months of being at more than 90% ideal body weight before menses resume. So some degree of patience may sometimes be necessary in terms of when to expect periods to come back. Having said that, if there is persistent amenorrhea after somebody attains a healthy weight, one should consider other causes of amenorrhea as well, such as persistent emotional stress or even underlying PCOS. Now, here's a look at the change in lumbar bone density that occurs over a 1-year period in healthy controls in blue, and these girls have the expected increase in bone density over time. In girls with anorexia nervosa who do not gain weight or resume menses, shown in red, who have a decrease in bone density over time, and girls with anorexia nervosa who gain weight and resume menses, shown in green, who have an improvement in bone density, although not quite to the extent seen in the controls. So, but this still emphasizes the impact of weight gain and menses resumption on bone density. So again, to come back to our case, these were her bone density Z-scores to start with, and we did put in place a multidisciplinary treatment team for her. We optimized her vitamin D status, and with that, her weight went up about 8 pounds over a 6-month period. She got to 91% of her ideal body weight, which is still quite below the 100% ideal body weight mark of 154 pounds. And she remained amenorrheic and then had another stress fracture. So what, if any other treatment would one like to consider at this time? And so is this a good time to consider estrogen replacement given the impact of hypogonadism on bone? And the Endocrine Society guidelines, in fact, indicate that after 6 to 12 months of non-pharmacological treatment and further exercise restriction, one should consider estrogen replacement therapy. So what does this look like? Now, we know for sure that giving estrogen as a combined oral contraceptive pill is not effective in improving bone density in functional hypothalamic amenorrhea. So there are many studies that have looked into this, and this is one such study. This was a 12-month RCT in girls with anorexia nervosa between 11 and 17 years old, showing that the change in bone density at the lumbar spine and the total hip did not really differ in the group that received the combined oral contraceptive pill versus placebo. And this lack of efficacy of oral estrogen in improving bone density has been attributed to the IGF-1 suppressive effects of oral ethinyl estradiol because of hepatic first-pass metabolism. And this is important because IGF-1 is bone anabolic, and particularly during puberty, when IGF-1 levels are going up markedly, that is an important driver of the increase in bone mass that occurs during puberty. So if oral estrogen is not effective in improving bone density because it suppresses IGF-1, would giving estrogen by a non-oral route be more effective in improving bone density because it bypasses hepatic first-pass metabolism? So what about giving estrogen transdermally or vaginally or sublingually to such that it's absorbed systemically and bypasses hepatic first-pass metabolism? So we do have data for the transdermal route of estrogen administration shown here. So this is an 18-month RCT of in girls with anorexia nervosa between 12 and 18 years old of the transdermal 17-beta estradiol patch given with cyclic progestin shown in red, or placebo shown in black, and this was in anorexia nervosa. And we also followed healthy girls without any intervention for the duration of the study, and they are shown in the gray bars. And the figure shows a % change in spine bone density over 6, 12, and 18 months of the study in the randomization groups and the healthy controls. And as you can see, the girls who received the transdermal estrogen patch had a significant increase in bone density compared to placebo to approximate the bone accrual that was seen over the study duration in the healthy controls. And we also had similar data for hip bone density over time. Having said that, we were challenged on this study because we did not really have a head-to-head comparison of the effects of transdermal versus oral estrogen on IGF-1 and bone outcomes. And so we followed the study with a second study, and this was in oligo-amenorrheic athletes between 14 and 25 years old. And this was a 12-month RCT of transdermal estrogen given with cyclic progestin shown in red versus a combined oral contraceptive pill containing ethinyl estradiol shown in white or no estrogen shown in black. And as you can see, the girls who received the transdermal estrogen patch had a significant increase in bone density at the spine, the femoral neck, and the total hip compared to the pill group shown in white. And they also had significantly greater increases in lumbar spine and femoral neck bone density compared to the no estrogen group shown in black. And in this study, the increases in estradiol correlated positively with increases in bone density at the femoral neck and the total hip. Now, we also looked at HRPQ-CT endpoints in the study and showed that at both the distal radius, a site of non-weight-bearing bone, and the distal tibia, a site of weight-bearing bone, the patch group in red compared to the pill group in white had a significant increase in cortical area, cortical thickness, and total volumetric bone density. And the patch group compared to the no estrogen group in black had a significant increase in radial cortical area and thickness and in tibial cortical area. And further, the patch versus the pill group had greater increases in tibial trabecular number and trabecular volumetric bone density. So these data were very clear that the transdermal estrogen patch, but not the combined oral contraceptive pill, is effective in improving bone outcomes in functional hypothalamic amenorrhea. Now, we next looked at the impact of transdermal versus oral versus no estrogen on biochemical endpoints, and this paper was first authored by Vibha Singhal. And we showed in the study that the pill group did indeed have a significant reduction in IGF-1Z scores that was not seen in the patch group or the no estrogen group. And this was commensurate with a significant reduction in P1NP, which is a bone formation marker, in the pill group compared to the other two groups. And the girls who had the greatest reductions in IGF-1 had the greatest reductions in this bone formation marker. And these data are consistent with IGF-1 suppression contributing to the lack of efficacy of the oral pill. And I won't have the time to show a lot of the other data that we had in the study, but just I'm going to summarize this by saying that the pill arm had increases in sex hormone binding globulin, which is the binding protein of the sex steroids, with reductions in bioavailable sex steroids. And the patch arm had reductions in sclerostin, PREF1, and BDNF, all of which inhibit osteoblastic activity. So with reductions in these hormones, there would be an increase in osteoblastic activity. So there are multiple mechanisms really that explain why the patch and not the pill would be effective in improving bone outcomes in functional hypothalamic amenorrhea. So based upon these and other studies, the Endocrine Society guidelines indicate that, or they suggest against using combined oral contraceptive pills in functional hypothalamic amenorrhea for the sole purpose of regaining menses and improving bone improving bone density. But they do suggest the short-term use of transdermal estradiol with cyclic oral progestin, but not a combined oral contraceptive pill, if menses do not resume after 6 to 12 months of a reasonable trial of nutritional, psychological, and exercise intervention. And one thing I do want to emphasize is that the transdermal estrogen patch given with cyclic progestin has no contraceptive efficacy. So this is something that needs to be, that patients need to be counseled about. So our patient was started on transdermal estrogen with cyclic oral progestin, and with that, she achieved estradiol levels in the therapeutic range. We want to have levels between 80 and 120 picograms per ml. We maintained her 25-hydroxy-D levels in the normal range. And with this, over a 1-year period, she had an improvement in her spine and hip bone density Z-scores by about a point. So this was quite a significant improvement, and that was great, but she continued to have stress fractures every few months. So at this point of time, what other labs or treatment would one like to consider? For example, is it time to consider genetic studies for osteogenesis imperfecta? And in this particular patient who had this profoundly low bone density at the spine, we decided to go ahead and actually get a 23-gene OI panel for her, and she tested negative for all those genes. And this is relevant because it's clinically relevant to get this, because if she indeed had OI, then a very good option for her would have been bisphosphonates at this time. So what other treatment strategies can we offer her? So thinking about bone anabolic agents, there are several bone anabolic agents and that stimulate bone formation. There are anti-resorptives that inhibit bone loss, and there is combination therapy. Now, for the bone anabolic agents, we have data in functional hypothalamic amenorrhea for dehydroepiandrosterone, IGF-I, leptin, and teriparatide. And for the anti-resorptives, we have data for bisphosphonates. So let's start with the bone anabolic agents, which increase bone formation by stimulating osteoblastic activity. So here are data for dehydroepiandrosterone, which is a weekly bone anabolic hormone and is also anti-resorptive. And this study was done by Catherine Gordon's group at Boston Children's. This was an 18-month RCT in teenagers and young women with anorexia nervosa between 13 and 27 years old, where the women were randomized to receive either dehydroepiandrosterone with a combined oral contraceptive pill, so combining an anabolic and anti-resorptive regimen, versus placebo for the 18-month period. And the study showed a maintenance of bone density Z-scores with this combination regimen that was not seen in the placebo group, which had a decrease in bone density Z-scores over time. Now, more recently, the same group has published a second paper, and this is a 12-month RCT in younger girls with anorexia nervosa between 11 and 17 years old. And this study showed some very different data. So amongst the girls who had closed epiphysis, meaning that they were done growing, the combination regimen did not really differ from placebo for effects on bone. And in those who were still growing with open epiphysis, the combination regimen actually fared worse than the placebo arm. And so these data suggest that while this combination regimen may be effective in young adults, it is not effective in adolescents with anorexia nervosa, and it could in fact be deleterious in those who are still growing. Now, with regards to IGF-I, so this is again a bone anabolic hormone, and we have shown in a study that giving IGF-I for a short duration does lead to a significant increase in P1NP, which is a bone formation marker. And this is an RCT in adults with anorexia nervosa by Steve Grinspoon in our group. And this figure shows the % change in spine bone density in the 4 randomization groups, the first of which received IGF-I with estrogen, and this was estrogen given as a combined oral contraceptive pill. So IGF-I is bone anabolic, estrogen would be anti-resorptive, versus IGF-I alone or estrogen alone or neither. And as you can see, the combination regimen had a significant increase in bone density compared to the group that received neither. But in a study of adolescents with anorexia nervosa, and this paper was first authored by Vibha Singhal, we showed that adding IGF-I to transdermal estrogen as opposed to the combined oral contraceptive pill does not further improve bone density in these young women. And with regards to leptin, so leptin is bone anabolic, this is from a study by Corinne Welt and others. This was an RCT of metroleptin versus placebo in women with functional hypothalamic amenorrhea. And the study showed that bone formation markers went up significantly in the leptin group, consistent with it being bone anabolic. But I've told you that leptin is anorexigenic, it inhibits appetite, and consistent with that, the women who received leptin reported a significant reduction in appetite, and they had a significant reduction in body weight as well, which would not be an optimal outcome in functional hypothalamic amenorrhea. And with regards to teriparatide, so this is a very powerful bone anabolic hormone, and these are data from a study from our unit, which was first authored by Poonam Fazali. And the study was done in older adults with anorexia nervosa of teriparatide in red versus placebo in black, showing that the teriparatide group had a significant improvement in spine bone density measures. We have no data for teriparatide in adolescents with functional hypothalamic amenorrhea in terms of improving bone outcomes. And we have no data in functional hypothalamic amenorrhea for other bone anabolics such as abaloparatide or romosozumab. And with regards to the anti-resorptives, for the bisphosphonates, so Karen Miller was the first author of this paper in adults with anorexia nervosa from our group. And this was a 12-month RCT of risedronate shown in red versus placebo in black. And as you can see, the risedronate group had a significant improvement in bone density z-scores at the spine compared to the placebo group. And similar data were observed for the hip as well. Now, in contrast to these data in adults with anorexia nervosa, Neville Golden's group did a study of alendronate versus placebo in adolescents with anorexia nervosa and found no impact of alendronate on bone density at the lumbar spine compared to placebo, although small increases were noted at the femoral neck. Now, there are concerns regarding using bisphosphonates in young people, given their very long half-life, although most data seem to suggest that this is not going to be deleterious in terms of teratogenicity, which was the major concern. And for denosumab, at this point, we have no data in athletes. We have just completed a study in anorexia nervosa showing that denosumab compared to placebo does improve spine bone density measures. So based upon some of these studies and others, the Endocrine Society guidelines suggest against using leptin, bisphosphonates, and denosumab to improve bone density in young women with functional hypothalamic amenorrhea. And the guidelines suggest that in rare adults with functional hypothalamic amenorrhea, the short-term use of recombinant PTH, which is teriparatide, is an option in the setting of delayed fracture healing and very low bone density. So our patient did receive 3 months of teriparatide, and we followed this with zoledronic acid infusions. So this is another bisphosphonate given annually. And with that, her stress fractures have finally stopped, and her bone density is now improved with the z-score for the spine being at -2.4 and the hip being at -0.8. And just to remind you, she was less than -4 for the spine when we started treating her, and the hip was below -2. So this is a definite improvement, but the spine bone density z-scores are still quite low. So to summarize what I've said so far regarding the treatment of functional hypothalamic amenorrhea and the associated low bone density, it is very important to put in place a treatment team that includes a physician, a dietitian, a mental health professional, and the parents and the athletic trainer and coach need to be in the treatment team as well. The first strategy is always lifestyle modification, and this includes improving caloric intake with or without a reduction in exercise activity. Therapy such as family-based therapy, cognitive behavioral therapy can be very effective in these young women. One should be optimizing vitamin D status. And if, despite these measures, amenorrhea persists, and in those situations, estrogen replacement should be considered. And this involves the use of transdermal 17-beta estradiol with cyclic progestin and not a combined oral contraceptive pill. And if, despite giving estrogen replacement, the patient is still having fractures, then one might consider other therapies such as teriparatide with or without bisphosphonates. But this should really be the last resort, and we want to minimize the use of teriparatide and bisphosphonates in young people. So I'll end by acknowledging all the people that have worked on these studies or referred patients to our studies, and I really want to acknowledge our study coordinators who do such a tremendous job of recruiting patients for these trials and retaining them in these trials. So it really takes a village to get these clinical trials done, and there's just a tremendous amount of work that goes into these studies. So thank you very much, and I'll end here, and I'm happy to take any questions.
Thank you, Dr. Misra, for an illuminating and interesting presentation. We do have some questions here. Question number one, most of the studies referenced here have relatively short outcomes. Are there any large cohort studies with longer term outcomes?
So yeah, that's a great question. So thank you for that question, Dr. Gentleman. So there are studies in anorexia nervosa, not so much in athletes with amenorrhea, that have followed these women for long periods of time. And definitely the risk of fracture persists high over the duration of a lifespan. And even after these women recover their body weight and menstrual function, bone density may persist low, and that really speaks to the adolescent years being such a narrow window during which to optimize peak bone mass. And so it appears that if you miss that window, even if you recover in the long run, your bone density kind of still doesn't quite catch up. So there are definitely cohort studies that have either followed the women for a long period of time, or cross-sectional studies that have looked back at anorexia nervosa and when it developed and how long people have had it for. Mm-hmm. And then there's a question about non-weight-bearing athletes like swimmers versus runners. So that's a great point. And with the non-weight-bearing athletes, such as swimmers, it kind of really depends upon what their body weight is and what their menstrual status is. And so certainly, the swimmers tend to have higher body weight in general than the runners. And so that is somewhat protective. Certainly if they develop amenorrhea, that again increases the risk for low bone density. It might not be as profound as when you have low energy availability and low body weight, as well as the menstrual dysfunction. There is one group of athletes that actually seems to be quite resilient in terms of their bones, even when they develop menstrual dysfunction, and those are the gymnasts. And maybe it is the nature of activity where they have those impact loading activities with the jumping and such. That seems to be somewhat protected to their bones.
Thank you. We have another question here. Dr. Misra, would you assess bone density in male athletes or in males with anorexia? And are there any treatments for low bone density in males after lifestyle modifications attempted?
So that's a great question. And I think there's been good work from Dr. Nagata regarding this issue. So yeah, bone density in males with anorexia nervosa is also significantly lower than seen in controls. And in terms of treating males with anorexia nervosa, that has been a particular challenge. Definitely lifestyle modifications would be the way to go. We tried to do a study of testosterone replacement in males with anorexia nervosa who have low testosterone levels several years ago, and we actually got nobody to enroll in the studies. I think there's a concern regarding the use of testosterone in many of these young men, because many are sports people, and testosterone, of course, is an issue in that regard. But the other thing to also know is that male athletes, even when they have a significant amount of physical activity, they tend to be more resilient than female athletes in terms of the gonadal function. So while you can have a female athlete who loses her periods with even 20 to 30 miles of running per week, it typically will require a male athlete running more than 60 miles per week, or at least more than 40 miles per week before you start to see the testosterone levels go down. So there is a degree of resilience in male athletes as compared to women.
Mm-hmm. Thank you. We have another one here. One of the old treatments for functional hypothalamic amenorrhea was naltrexone to generate LH surges. Has anybody looked at bone mineral density and weight trajectories?
So in terms of naltrexone and generating elite surges, one thing I did not mention in my talk today is that there have been some studies in functional hypothalamic amenorrhea looking at kisspeptin as a generator of GnRH pulses and LH and increasing LH secretion. So those studies are still in their infancy, and mostly because kisspeptin, is given as an infusion at this point. And so that can be hard to apply clinically, but I'll be really interested to see where those studies go in the future, because if there's a way to administer kisspeptin in a way that works to generate natural pulses and have an increase in the gonadal steroids, that could be a very cool mechanism, because that would address both the estrogen status and the testosterone status and potentially DHEA as well, as opposed to us giving estrogen replacement only.
Thank you. So the information on OCPs versus transdermal estradiol was interesting. We have a question here about, should we conclude from your presentation that giving oral OCPs in adolescents with athletes with amenorrhea is not indicated clinically with or without measuring low bone density?
Yeah, so I would suggest that if you have athletes with amenorrhea in your practice, they should be getting a bone density assessment. And with regards to oral contraceptive pills, the question really is, why are you giving the oral contraceptive pill? If you're giving it for contraception, then I would give it because you definitely want these young women not to get pregnant. That's, even if they are amenorrheic, they could potentially ovulate every now and then, and that certainly does happen. So that's very important. But if you're giving it for inducing periods or for improving bone density, it might induce periods, but that's almost a false sense of security, because those periods are really not doing anything because it's not improving the bone health. And just getting the periods back per se is not doing anything for them, other than helping them feel that they're okay, and they're not.
And I'm going to piggyback on that, Dr. Misra. If someone was seeking birth control and you wanted to increase bone density, could you do transdermal 17-beta estradiol and a progesterone IUD or some other form of progestin birth control at the same time?
Yeah, so that really would be the way to go. And if they would do a progestin releasing IUD with a transdermal estrogen, that would be fantastic. They don't need cyclic progestin with that, because the IUD would protect the endometrium. So I would definitely suggest that as a great strategy for contraception, and while also optimizing bone density.
Thank you. And then we have another question. What about early preventative strategies in committed athletes?
Yeah, so that's a great point, and I would say absolutely that's exactly the way to go. And for a long time, athletes believed that it was appropriate to have irregular periods or lose their periods, because that was believed to be a sign of practicing enough. And coaches really bought into that, idea. And so a lot of work has gone into educating coaches and athletic trainers at this time about functional hypothalamic amenorrhea and its consequences. And so the hope is that as more education is done, that there will be an increasing emphasis at preventing this from happening in the first place. So addressing the low energy availability state early on, ensuring that they get enough caloric intake such that they don't develop a state of energy deficit.
And finally, Dr. Misra, you presented studies on transdermal 17-beta estradiol. What about the use of oral 17-beta estradiol in improving bone density? Do we know anything about that?
Right. So this is, again, a very good question. We haven't done those studies, and neither has anybody else. So we don't know the answer to that. I can tell you that there are studies in Turner syndrome by Nelly Moraz's group looking at giving estrogen transdermally versus orally, suggesting that both would work equally well if they're both 17-beta estradiol and not ethinyl estradiol, which is what we see in combined oral contraceptive pills. Having said that, those were not women with energy deficit, and there are studies in postmenopausal women for sure that have shown that giving oral 17-beta estradiol does lead to a significant reduction in IGF-I compared to transdermal 17-beta estradiol. So it might work. I just don't know whether it's going to work as effectively as transdermal estrogen.
I would love to thank you for an amazing presentation and an active discussion time. Thank you so much for your time today and your expertise.
Thank you so much for everybody's attention. I really appreciate the invitation, and have a great evening.
Yeah, thank you so much. And everybody, thanks so much for being here. And we'll look forward to hearing from you again in the future and to see everybody at next week's Grand Round.
Bye-bye.
Bye, everyone.